Hi everyone, thank you for the opportunity to give this talk. I'm part of a very different kind of research team, I think that most of you belong to. I'm part of a research team that is multidisciplinary, and when I mean multidisciplinary, we have anthropologists, economists, psychologists in the research team. So for me, it's very refreshing to be able to focus a bit on aptamers and science, more like biochemistry, chemistry, or biology. So I'm really looking forward to feedbacks and discussion on what I'm going to present to you today. It's also very humbling because it's not a project that we have many people working on. We don't have that much money. So obviously we like the small league players compared to the big champions I've presented so far. So bear that in mind. And so what we have been interested in is looking at Aptamers to look at ovarian cancer biomarkers. So within the research team, CHROM means emerging and chronic risks addressing the population. And so within that team, I'm interested in the part that's the organization, well-being, and security of population. And so the purpose of the work that I started doing in Aptamers was to be able to set up silex in the lab, to be able to use it in a very different kind of environment. We want to be able to use it in polluted water, in seawater, in wastewater samples from the water treatment station, and very different kind of situations. So that's why Aptamers was a good comparison compared to antibodies, for example. And also in the case of the well-being, I wanted to be able to use Aptamer in a situation where we kind of can look at the ratio of survival rate versus incidence rate in the situation of cancer. And so if we look more specifically about ovarian cancer, I guess some of the things didn't go through. So here you have a map of age standards incidence of ovarian cancer. Ovarian cancer is considered a fairly rare cancer. If we look at the number in 2020, obviously numbers afterwards are a bit not very clear with the impact of COVID. But 300,000 new cases have been diagnosed in 2020. It's the repartition in the world is not so much the same. If you look at Central and Eastern Europe, it's a bit more present than the average occurrence, which is 6.6 per 100,000 women. But if we focus on the UK, because we're in the UK today, it means that there's 7,000 new cases per year and 4,000 deaths per year. So that means 1 in 56 UK females will be concerned with ovarian cancer in the course of life, and that represents 11 deaths per day. So it may not seem like that much, but we are still interested in that survival versus incidence ratio. So ovarian cancer, I'm using it as a single disease, but it's actually a heterogeneous group of disease. And main kind of ovarian cancer is called epithelial ovarian cancer, and it depends on where the epithelial cells come from. Many different situations of histological classification have been going on, with the World Health Organization providing the latest standards for 2020. And there's also more rare type of cancer that's about 10% of the cancer, but that's much lower occurrence than the rest. So if we focus on that situation of mortality versus incidence, obviously, if you look at breast cancer concerns about like 8 million women that were diagnosed in the last 5 years. But we should focus on the difference between the orange, which is the incidence, and the gray for breast cancer. We see that there's a huge difference. And in the case of ovarian cancer, it's not such the same. It's the 8th most common cancer worldwide, but it's the most lethal gynecological cancer. And if we focus here on the data here, you see the incidence here in orange, and in gray, you see the mortality. That means what we can see is that basically only 1/3 of the women who have been diagnosed with ovarian cancer survive. And that's one of the cancer where the progress is the slowest, and there's a different reason for that. And in our case, what we wanted to try to tackle was the early diagnosis version. The reason why the survival rate is so low is that most of the time it's diagnosed at later stage. However, the survival rate is much better if we are within stage 1 or stage 2, and the survival rate at 5 years is higher than 90%. If we go to stage 3 or stage 4 at the time of diagnosis, the survival rate drops below 30%. And as you can see on the data at that bottom here, you're looking at UK, Ireland, Denmark, Canada. we see that in most cases, women are diagnosed at later stages. Obviously, that links that to a lower survival rate. And one of the issues is that there are not very specific risks for ovarian cancer. So we know now that lifestyle, like in many cancers, can have an impact. In the case of ovarian cancer, lifestyle accounts for about 21% of the ovarian cancer through obesity, diet, smoking, using baby powder, for example. There's also a bit that is due to genetic mutation for people who have BRCA1 or BRCA2 mutation. However, the main factor for ovarian cancer is age, basically, being a woman of over 65 years old. What can have an impact is the number of pregnancy, basically the number of ovulation rate, if women have late menopause, or if they didn't breastfeed or didn't have pregnancy, the risk of ovarian cancer is higher. But because the age seems to be the highest impacted on the risk, the prediction is that by 2035, the rate of ovarian cancer is going to increase by 55%. So that means we have women that are going to live longer, more likely to get cancer that we still cannot cure very satisfyingly, in a very satisfying manner. And compared to other cancers, the survival rate right now has improved because therapies are better and because we're able to keep women in recurring ovarian cancer alive longer. But not because we can detect it earlier or because we can reduce also the impact that the surgery can have. One other issue also is that the symptoms are not really specific. Fatigue, weight loss, pain in stomach, bloating, appetite loss, basically anything that shows that it's taking place within the pelvic area, and that's about it. Some of the research now show that it may be possible to pinpoint a bit more, but it's still not a very common acceptance that symptoms are very specific for ovarian cancer. So in this situation, our goal here was to be able to provide a test that would be cheap, hence Aptamers, that would be resistant throughout time, to have available for general practitioner, to have and provide the test for women who may exhibit some of the symptoms and maybe feel some of those risk factors, to then do a quick test. So obviously we wanted to use Aptamers that would recognize a specific target. And once we have that probe target complex, then move on to biosensor. What we specifically wanted to do is to use urine, because urine is a large quantity of biofluid that's available, that is non-invasive, and that would be able to provide also quick results. And so the idea is to have a test. Obviously, we're not at that stage yet, where based on the results of the test, if the results say that there's a potential for ovarian cancer, go and get some more checkup with specialists, or then try to look for some other reason for why you have those symptoms. So urine is, the main reason for urine is to be able to develop that point of care kind of settings, to have something that's non-invasive, less complex. Keep in mind that we also want to be able to use later on in the lab the concept of Aptamer and Silex in non-very friendly environments such as polluted water and so on. That's why urine was also a good idea. We use artificial urine with the composition that's provided here on the slide from nature. But one of the key aspects here was the non-invasive aspect. It has been mentioned in the talk just before, and it's something that's becoming more and more important in the way we have patients that seem to be more or less proactive in their health. Because so far for ovarian cancer, the main diagnostic are physical exam, pelvic exam, and that's really not the most satisfying one. It's a serum test of cancer antigen 125 or transvaginal ultrasound. C125 so far is the gold standard, so that means it's going to be used all the time. However, it's a marker that's not going to be present in 50% of the ovarian cancer at the early stages. That means it's not very satisfying to be able to diagnose early. And so those diagnostics are not very specific because transvaginal ultrasound also depends a lot on the operator ability. It's invasive. And the reason why we believe it's invasive is because when we did with the psychologist part of the Chrome research team, a questionnaire where we asked people if they consider some of these tests to be invasive. So what you see here are the number of people that replied. We had 105 people taking this questionnaire. If they did find that the pelvic exam was something invasive, we had more than 40% of the people that did find it invasive or very invasive. And it goes even higher for if we cumulate invasive and very invasive for transvaginal ultrasound. And looking at the negative emotion that can be associated with diagnostic that may not be very, very present or very friendly. I don't know if we can have a friendly diagnostic. We then ask the next question: would those negative emotions cause a delay in you taking the next step for a doctor's visit, making the phone call or getting the appointment set up? And more than 40% of the people replied that indeed those negative emotions could lead to a delay. And because ovarian cancer is already what we call a silent killer, that means the disease evolves without the person knowing that she has cancer. If we wait even more, then obviously we progress to the stage 3 and stage 4. If we move on then to this next question, that would urine be a solution? Then when we ask if the test with the same characteristic, would people prefer a blood sample or urine sample first? 49% of the people replied urine first. So that was something that was useful in our idea to set up a point of care system based on urine. Obviously, aptamers are a very useful situation. And specifically in this case, we wanted them to be stable at various pH and temperature. Because when we started this project, we didn't have all the answers from the questionnaire that we sent out. And it turns out that we saw that with the COVID situation, people would be more willing to do the test themselves. However, when we asked people if they would be willing to collect the urine at home, and we had a collaboration with Novasanis on this kind of device to be able to collect the urine, sorry. More than half of the people considered that collecting the urine at home was better. However, when we asked whether they would be willing to do the testing themselves, and that was after COVID, obviously, only 20% of the people agreed to do the test. And when we discussed with patients' association, for COVID, it was fine. But for verdict as strong as cancer, people did not want to be left alone, did not want to be in the situation where they may have to bear the responsibility of whether the test was done or not properly. So that way, for us, it was important to have something that's stable, because as we are developing the test now, we don't know whether we would want the, for example, the aptamer to be giving a signal here or to do some testing later. So when we look at the literature that was done in ovarian cancer, several studies have been done on C125. C125 is not a very easy protein to work with, and there was one done with HE4. However, in all cases, those aptamers were not developed nor applied in urine. So that's what we wanted, really something in urine. And they also were not tested in concentration relevant to patients. Obviously, you want to be able to test them in patients. It has to be in concentration that are significant. So we decided to target HE4. It's a small protein that's glycoprotein that's secreted in the blood. It's overexpressed in all types of ovarian cancer. If you remember, I told you at the beginning that it's an heterogeneous disease. And it's also present in early stages of ovarian cancer in more than 80% of the case. That means we're in a better situation than the gold standard, actually, that's C125. It's currently used in an algorithm that is used by doctors in association with CA125 for estimating the ovarian cancer situation. It's validated biomarker in serum, actually, for recurring ovarian cancer, and as a single biomarker. So obviously, right now, we focus on a single biomarker, but the idea is to expand it to several biomarkers. It has the highest sensitivity and specificity for ovarian cancer detection. And that's in serum, where it has been validated so far. And because it's a small protein, it can be found then in urine. It has the same diagnostic value in urine than in blood. And also, it's very stable in urine, because the idea is that we want to be able to get a urine sample and at kind of any time of the day to be able to get the results. So that means urine in this situation is an alternative source of HE4, and it's a less invasive. So obviously, we went on to do SELEX. So we decided to do hi-fi SELEX, meaning that the amplification was taking place using digital droplets. Because we are a multidisciplinary team, we had to work with DNA. I come from the RNA world, but we had to work with DNA. Aptamers, as some people in the next bench are working water treatment samples. Some of them are working with tomatoes to see what's the impact of pesticides on tomatoes. And also because we still have this idea that we want to have silex that works in stringent environment. So we used a random region of 30 nucleotides and a fixed region of 20 nucleotides so far. I'm sure for many of you this is very simple, but it took us quite a while to find the good library for us. And it turns out, as it was mentioned in the talk earlier, then what we ordered actually was not what we got, and that's some information that we got from the sequencing afterwards. We had the specificity that we put on the ACG2 proportion, and that's not at all what we had when we received the library and we sequenced the library. And that's something that may lead to the fact that we need to do a bit more cycles. So we ended up doing 10 cycles. And for the last 2 cycles, what we obtained from the cycle 8, we split it in half to do a positive selection. So with HE4, which is shown here in blue, and part was for the counter selection with histidine peptide. We had to use HISTAC HE4 because it's a glycosylated protein. It was not possible to produce it out. And because it was the first kind of silex that we were doing in the lab, we wanted to make sure that we had different ways of checking it. So for the droplet PCR, the talk just, not before, but right before, talked about the concept of droplets. So we used that droplet PCR with the idea that we wanted to make sure that we did not lose rare sequences, because we're working with a DNA with a protein that's not necessarily very positively charged. We wanted to make sure that it was something that was specific and was not going to be lost in issue of amplification. And so the way droplet PCR works is that if you have the signal that's around 6,000, it's the single-stranded version, no amplification has taken place. That 12,000 around is the double-stranded version, and here are the negative droplets. The idea was to get a higher presentation, a higher diversity of the library, to make sure that we get rare Aptamers amplification. We wanted to get something that was also very sensitive, because we are new to the silex Aptamer world. And we wanted to make sure also that we had duplex at the end of every step. So these are the results that we got. So at the beginning, we had too much of the DNA that was present in the droplet, so we didn't have amplification. That took us a while to figure out. And then afterwards, we were able to get, first of all, enough droplets and to be able to get the amplification going on. And what is interesting to see here is that for the counter selection, we have not as much amplification. So that means that we indeed have counter selection that is working in a satisfying manner. So this is a slide that the PhD candidate that worked on this was very proud to get. So at each cycle that we validated, obviously keep in mind we are new to the silex Aptamer world. And so we had the distinction between the single-stranded DNA and the double-stranded DNA. We had to overcome some of the issue of not getting all the reagents we wanted. The post-COVID situation lasted quite a while in the lab. And we were able to get here the same size of DNA at each cycle. It was mentioned in the talk earlier that sometimes you just can stop at 6 cycles. We tried to actually do in parallel in buffer and in urine. And at the end, it started to be too much, and we stayed in buffer. But I do believe indeed that we had the best binders were selected at cycle 6, and we kept them throughout, and maybe it's hopefully thanks to the droplet PCR. But because we had such a bias, and we didn't know we had this bias in the library that we ordered versus what we received, we did a sequencing at cycle 5, and so we wanted to make sure that we did not have consequence from this bias if we stopped at cycle 5. For example, we had a very huge underrepresentation of Cs, and we see a lot of Cs that appeared afterwards. So after the second round of selection with a collaborator in CEA, we did next generation sequencing, and we ended up with about 3,000 sequences that were okay. When we looked at M-fold analysis, in a fold analysis, it's not very satisfying. Basically, you have huge loops, not much going on, so it was not very encouraging. But we still decided to continue. So here are the sequences if you're interested, and so that's what was mentioned. Basically, the base binder here appeared already at cycle 7, and we kept it until cycle 10, and actually the presence of this base binder at cycle 10 was a bit less than cycle 9. And so what we did to characterize interaction, we did thermofluorimetric analysis. So this is the situation where you have an intercalating dye and you measure the melting temp of the aptamer that's free without the target with intercalating dye. You add the target and you see whether the melting temperature is changing. Some papers mention that the melting temperature can be lower with the target. It was not the case in our situation. The melting temperature increased all the time. And so this is kind of what it looks like. This is the melting temperature of the aptamer alone. And when we increase the concentration of HE4, so we measure here this difference in melting temperature. Sorry. And then we were able to get dissociation, for instance, in the nanomolar range. That was quite encouraging because when we look at the literature, sometimes some of them are in the low micromolar. I'd rather be in the high nanomolar than the low micromolar. And so we continued on trying to characterize some of those aptamers using SPR. So I'm not showing you the data because they're even worse than some of them that were shown earlier. And one of the reasons we believe is that the fixed region on each side we believe are important for the structure. And when we did the SPR, we did not put the fixed region, and so it helped us to get some discrimination, but it was not enough to get some good binding data. And so what the SPR showed us is that also that the on and off rate were fast enough if we intended to then move on to a point of care assay. And so we tested some of the primers from the literature as well that were targeting HE4, and they didn't work that well in urine. They didn't work that well in all the tests we did. Obviously, ours were better. You can have to give us that's a good point at some point. And so what we did find, though, is that we were able to get interaction in urine, and that interaction in urine was better than interaction in buffer. So that means the selection in urine was actually something that was useful and significant. And so when I said we were in the high nanomolar range, we had about 90 to 120 nanomolar for two of the aptamers that we characterized the most. This was not supposed to be there. We looked also at the impact of the 5' versus 3', and this is very preliminary data. I didn't want to show them. I guess PC and MAC is a bit different. And we do see that the 5' versus 3' has an impact, so that's something that we need to look further at. But then we arrived at the step of the proof of concept with a collaborator at the French Blood Bank. We used the Oriva platform, and we look at, so that's an assay that looks at the turbidity. So you look at the agglutination that can take place. So we still had to work in this situation with the histag version of the HE4 because the two aptamers we have, they bind to the same area, so we can't use the two aptamers. And when we try to do ELISA comparison in ELONA, the antibody bind in the same place where the aptamer is binding so far. So what we were able to see and we're very happy about is that in that very preliminary data is that we had binding that was first HE4 dependent, that's still in artificial urine in spike samples. And we actually had results within a range that was significant to patients. So in conclusion, that means that we can select aptamers in urine. That means in the future, maybe we will be able to use seawater or different kind of non too much lab relevant situation, and that urine is a great source of biomarker for non-invasive and high affinity probes. Obviously, we have to optimize the sequence that has been mentioned throughout the day, that there's a lot of labor that's involved in the optimization of the sequence when we have them. And we obviously want to move on to test in actual patient sample and not artificial urines to be able to then further develop the aptassembly. And if we're able to detect HE4, it would be a great tool for ovarian cancer, I hope. The idea is to keep on looking at other markers to have obviously a multi-panel assay. And so I want to thank the members of the lab that did the work, mainly PhD student Anthony Anchak, our different collaborators, Frédéric Ducongé for the next generation sequencing and analysis, the RCM people for the SPR data, the EFS for the point of concept, for proof of concept we have, and different source of support. And thank you for your attention.